Hi, this is Brian Kim. I'm going to share with you case number 61 in the Best Way to Do Cataract Surgery series. This is a dense cataract, and you'll see systematic lens disassembly using double chop, cross chop, mechanical fracturing, and minimal ultrasonic energy usage. So first things first, I like to have a meticulous draping, and anytime there's lashes, I want to cut the lashes and get them out of the field. And so that's first order here. And profuse irrigation as well, because a lot of material can get liberated from the lids and the lashes. I'm using a corneal marker to help me center and size my rhexis, and then using a cotton tip, I'm going to turn the eye and make my paracentesis incisions to the right and then the left side. And I want to make my incision flat to the iris plane. Again, I'm using a cotton tip here. This is a rod eye. This patient has a strong Bell's reflex. I'm using a cotton tip to turn the eye down, and then I'm making my left paracentesis incision flat to the iris plane, so I get a nice corneal shelf, and this will allow me to get a nice self-sealing corneal incision. So I'm going to inject some intracameral lidocaine here, and then some intracameral dispersive viscoelastic to fill the anterior chamber. And this patient, again, has a strong Bell's reflex, and I'm going to use that cannula to control the eye. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, turn the eye back towards me using the cannula, and then enter. And that's the triplanar corneal incision. I'm going to begin my puncture style capsular rhexis, placing the forceps in sideways, and then I'm going to puncture the center, pull downward, grab the edge of the tear there to create a flap, and I'm going to go counterclockwise, making sure I grab and re-grab. I'm trying to stay within the confines of my corneal marker. I'm going to be very careful going around, not pressing on the incision, which will cause more viscoelastic egress and loss of control of the rhexis if that happens. So I'm grabbing and re-grabbing, and then I finish off the rhexis and then burp some viscoelastic out. And this is the capsular fornix hydrodissection technique. I place the cannula out underneath the rhexis edge contra-incisionally into the fornix, pointed down, get a nice fluid wave, decompress on the left side, point the tip down, and the lens starts to spin. I tried to do a hydrodelineation in that step. I'm not sure if it was effective or not, but it was worth a try. I do feel a little bit wary about pushing high pressure into the bag like that, so I just give it a one-time try there. I also was concerned that maybe this patient was going to have a floppy iris, and so I went ahead and injected some more epinephrine around the pupillary edge and underneath the iris. And so you can always inject more epinephrine at any time during the case, even if there's viscoelastic in the eye. So I'm irrigating the surface of the cornea with the water. Lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. Remove the surface epinuclear material, place the chopper underneath the ridge, out to the capsular fornix, point the phaco tip vertically subincisionally, bring both instruments together, crushing the lens completely in half, separating the instruments to divide the lens completely. Place the chopper underneath the right heminucleus, pull it centrally towards the phaco tip, crushing and dividing the right heminucleus in half. Again, that's the double chop and then the cross chop maneuver. Place the chopper underneath that first quadrant, pulling it centrally against the phaco tip and dividing that first quadrant and separating it and cracking it, using a little bit of vacuum to pull that piece up, crushing the lens material between the chopper and the phaco tip and emulsifying the lens piece. Going after that remainder of the first quadrant, pulling the lens piece with the chopper against the phaco tip, cracking and dividing it, and then emulsifying the fragments. Crushing the lens piece between the chopper and phaco tip to make it smaller, and then emulsify the lens pieces. Manipulating the second quadrant in front of me here, place the chopper underneath the rexus edge around the lens piece, pulling it centrally towards the phaco tip, dividing that second quadrant. Using a little bit of vacuum to lift the piece up, and then sandwiching the lens between the chopper and the phaco tip and emulsifying the lens pieces. This is the last part of that second quadrant. I'm manipulating it with the chopper and then lifting it with some vacuum with the phaco tip, sandwiching the lens piece between the chopper and the phaco tip, crushing it into smaller pieces, and then emulsifying the lens pieces. I'm going to rotate the second heminucleus in front of me very carefully and gently rotating it. Place the chopper around the heminucleus, pull it centrally toward the phaco tip, dividing that second hemisphere into third and fourth quadrants. Place the chopper around the third quadrant, pulling it centrally towards the phaco tip, dividing that third quadrant into smaller pieces, using some vacuum to pull the fragment up, crushing it between the chopper and the phaco tip, and emulsifying the lens pieces. Manipulating that last part of the third quadrant, place the chopper around the lens piece, pulling it towards the phaco tip, crushing and dividing that fragment, pulling it up with some vacuum, crushing it between the chopper and the phaco tip, and emulsifying the lens pieces into smaller pieces. Again, this is a very controlled way to disassemble the lens. You're using minimal ultrasonic energy. You're using mechanical fracturing forces to crush the lens pieces into smaller pieces. You're able to use mechanical fracturing techniques to pull lens pieces up out of the bag. You don't have to rely on and depend upon spinning the lens within the bag. You're able to attack the lens in any configuration, which is a very versatile way to disassemble the lens, and also use reduced ultrasonic energy, which does lead to clearer corneas after surgery. I manipulate that fourth quadrant in front of me, place the chopper around that quadrant, pulling it centrally, crushing the lens piece against the phaco tip, and emulsifying the lens pieces after crushing them into smaller pieces. I place the chopper around the last fragment, pulling it centrally and crushing it against the phaco tip, using successive mechanical fracturing maneuvers, crushing the pieces into smaller pieces, and then emulsifying the lens pieces. And I continue this maneuver and these techniques no matter if I have a bag full of lens or it's a small fragment, because it's a very controlled and systematic way to disassemble the lens. Utilizing minimal ultrasonic energy and vacuum, I feel like it's the safest way to disassemble the lens. So very carefully, I'm using vacuum to remove the epinuclear shell now. I take the chopper out, push BSS in, take the phaco tip out, and then place the INA handpiece in, and I'm polishing underneath the rexus edge very carefully. And the bag is fairly clean, so I switch to the polish mode fairly quickly here, polishing any potential lens epithelial cells under the rexus edge. Now I'm injecting some BSS into the subincisional capsular fornix. In this case, the bag is nice and clean, so I'm injecting some cohesive viscoelastic to fill the capsular bag, and then I'm going to polish underneath the rexus edge with the capsule sweep here. Polish on the left side and then the right side. With these very dense lenses, I prefer to place a 3-piece lens for more zonular bag capsule support, and in case there is a late dislocation, I can utilize that 3-piece lens still. So I have to widen my incision to accommodate the injector. I have the barrel facing to the left, start to deliver the leading haptic, which comes out planar, rotate the barrel 90 degrees counterclockwise to deliver the optic in the correct configuration. I use a Maltzman to dial the trailing haptic by pushing the optic-haptic junction. And I go in with the INA handpiece, go underneath the lens, tilting it up, removing all the viscoelastic from within the bag, repositing the lens back into the bag, polishing underneath the rexus edge here very carefully and gingerly. I'm just gently rotating the lens and then removing the viscoelastic from the anterior chamber. So again, this is quite a dense lens. It would have taken forever to sculpt the lens. I don't like lollipopping the lens with high vacuum and ultrasonic energy. I feel like using mechanical fracturing techniques, leveraging the use of the chopper and effic tip, both as mechanical fracturing instruments, crushing and sandwiching the lens pieces between the chopper and effic tip, and then breaking up the lens pieces to even smaller size pieces before emulsifying the lens piece. Again, this is a very controlled way and utilizes very minimal ultrasonic energy. You can disassemble very dense lenses this way and still have very clear corneas. I feel like this is also a very controlled way. Whenever you have a dense lens, you do have a higher risk for complications as well, zonular weakness, sometimes a floppy posterior capsule, and utilizing less ultrasonic energy and vacuum in this setting, I think, is always a good thing, especially in the very dense cataract situation. So I hope this was helpful to you, and I thank you for your attention.